Yes, sir.
Hello, Dr. Tripathi.
Hello.
Hey. So can we start now?
Yeah, please.
Yeah. So dear distinguished speakers and audience from across the world, I Somna Singh warmly welcome you on behalf of UN Global Compact Network India to our knowledge partner session at the 2021 OECD Global Anti-Corruption and Integrity Forum. Moving ahead, I would like to share a brief journey of UN Global Compact Network India on promoting and strengthening anti-corruption collective action in India. Starting in 2011, GSNI has been involved in all the rounds of global Siemens integrity initiative that support organization and project fighting corruption and fraud through collective action, education, and training. This collective action project, a 4-year project, was the first round of Siemens Integrity Initiative, provided a platform for anti-corruption dialogue to public and private sector businesses, and took pressing corruption issue in Indian context, that is public procurement, bribery, and fraud in the private sector, and supply chain transparency. A business case for transparency was also developed. Global Compact Network India furthered anti-corruption work through UK Prosperity Fund India project by promoting the relevance of integrity pact among public and private sector in India through the round two of Siemens Integrity Initiative, Global Compact Network India, which focused on promoting governance and ethics in businesses, and also established robust framework of governance and transparency in smart city development in India. And for the ongoing round three of Siemens Integrity, Global Compact Network India has been developing a local anti-corruption collective action initiative in the healthcare sector. We understand that the healthcare sector has one of the most vulnerable value chain for high corruption risk exposure during and after the COVID pandemic. In view of COVID situation, today's panel will deliberate on various relevant issues. And I'm sure that today's panel will create a platform to scale up anti-corruption collective action in India. Once again, I wish all the best to the eminent speakers for the productive discussion and success of the panel. So now I would like to request the moderator of the session, Mr. Swaz Tuljapurkar, to take the discussion ahead with the eminent speaker. Mr. Swaz Tuljapurkar.
Thank you very much, Dr. Somnath. A very warm welcome to everybody. Wish you all a very good evening, good morning, good afternoon. Uh, it's kind of we have audience and speakers across the globe today. So there are different time zones, and I also believe that this would be recorded and recording would be available. We also have a very interesting panel speakers today, and I'll come back to them uh, and I will try to introduce them very soon. But before that, I want to express gratitude. I want to express a sincere thanks to all the healthcare workers, to all the doctors, to all those who during COVID, during epidemic, during pandemic period, actually ensured that we all are safe. We all are alive. And I think to that effect, I must express my gratitude towards all those healthcare workers who have ensured that we all remain safe. Thank you very much. And no amount of words are sufficient to express this gratitude. Thanks to everybody. We have few of them amongst us today, and we will talk to them also. Secondly, I want to also kind of offer our prayers from UN Global Compact Network India and everybody here to those thousands of doctors who have lost their lives during COVID, to various kind of deaths that have occurred during COVID. And we all pray for them and we all join their families in the prayers. With that note, I want to kind of look at what is the theme today. And we're going to talk about collective action to fight healthcare corruption post-COVID era. I think the world today will get divided or trifurcated into three large eras. It's pre-COVID, during COVID era, and post-COVID era. Now, it's very clear that when does the COVID era begin and when does the pre-COVID era end? But I think when would the post-COVID era begin is a question that is there in everybody's mind today. But I think with vaccination being accelerated, we've sown hope that we're going to hit the post-COVID era as soon as one can expect it to be. We have excellent panel speakers, and thank you to each one of you. I'm going to briefly kind of take the names and try to kind of introduce you. Although, because of paucity of time, I won't be doing justice to your credentials. We have Sarah Stengruber. Did I get your name right, Sarah? Thank you. Thank you for joining, Sarah. And I think very interestingly, while while she's an independent global health consultant, she specializes in anti-corruption, transparency, and accountability, as well as to have access to the medicines, the global health supply chain, and private sector collective action. I'm not going to kind of name the institutes across where she is associated, and she has done a stellar work. Thank you very much, Sarah, for joining us on this panel today, and you're warm welcome. We have, Professor Dr. Christian Hauser. Hi, Christian. Very welcome. Welcome to this panel discussion. Do we have Christian?
Yes, here I am. Hello.
Oh, great. Great to see you again. Please pardon me. I probably would not do justice by reading your entire profile, but Professor Christian Hauser is in Switzerland, and thanks for joining from Switzerland. I think he's a professor of business economics, a fellow of Digital Society Initiatives, University of Zurich. He had some of the integrity actions and at the center across Europe. His research, especially in SME, private sector development, and ethics with digital movements and ethics with digital developments, is something of interest to all of us. And I think we will talk about some of those issues qua the topic and the healthcare here. We have Ashley and Deming. Thanks a lot, Ashley, and welcome, Christian, for joining, and a very warm evening from India. Ashley, thanks for joining us. And Ashley is manager anti-corruption UN Global Compact in New York. It's a collective action program that she drives. She's kind of has a phenomenal experience of working with with UN Global Compact, and I think I'm going to request Ashley subsequently to talk about it. Thanks and very welcome, Ashley, for joining us today, this evening, or early morning for you. Thank you very much. We have Mr. Neville Gandhi, our dear friend, and Neville is kind of has a phenomenal corporate experience. He is Vice President Compliance with Siemens AG, India. He's in charge of anti-corruption collective action initiatives implementation in India, and an extremely glued onto the agenda that we're going to talk about. Coming from corporate sector, there are various learnings that we have. And thanks a lot, Neville, for joining us, and very warm welcome to you.
You're welcome.
We also have, thank you, thanks a lot. We also have, Professor Dr. Narendra Malhotra, and I think Dr. Malhotra is Managing Director of Global Rainbow Healthcare. He's Director of ART Rainbow IVF, and he is a professional doctor amongst us, a person whom we will look forward to in terms of understanding the healthcare sector and the challenges currently in the healthcare sector. A very warm welcome, Dr. Professor Narendra Malhotra. Thanks for joining us this evening. You see, I'm going to kind of do a bit of looking at the topic and try to kind of say as to what are the things that today have been the experiences during COVID period to start off with. And I'm going to start off with Sarah as the opening remarks on the theme from you, Sarah, and I will try and do this round robin and look at how do we develop the dialogue. Sarah, over to you.
Sure. Thank you, Suhas. Thank you for those introductions. And also I would like to thank the Global Compact Network India for their invitation for me to speak today and to participate in this important event. So when it comes to collective action with regards to post-COVID, I think there's a lot to be learned from what's currently going on and the existing collective action that is occurring now. Certainly there is much room for improvement. I think a lot of post-COVID collective action will require a lot of taking stock and learning from what has transpired throughout the pandemic, but also looking back even further before what had been sort of the methods and approaches for collective action prior to the pandemic, so that we have a very strong learning and progression from what has been tried in the past and determining sort of what has worked best and as far as how we must go forward. I think within the health sector, and certainly there's many opportunities for collective action more broadly beyond the health sector, but with regards to the health sector, I think an important thing would be particularly, and this is from my observations, that there's a lot to be learned from collective action in securing supply chains. There have been a lot of threats made to supply chains throughout the pandemic, and in order to prevent this in the future, there's quite a lot of learning that we can make now about what has transpired. And I'd like to highlight one particular approach that I think is very useful and would bring in private sector very well, something that I'm involved in. And it's not to say that this type of approach should be done one-to-one, but this type of approach could be sort of a blueprint for supply chains. And that's the work of the Pharmaceutical Supply Chain Initiative, which these companies, it's a collection of over 40 companies, they share auditing for their suppliers. Now, this was a considerable concern, especially at the beginning of the pandemic. How can we cope with the increase in requirements, the increase in demand for products required in order to support and to satisfy global needs? And what this Pharmaceutical Supply Chain Initiative does, or PSCI, what they do is they share the auditing results. So everyone who is a part of this initiative understands who is a secure and reliable supplier. And by doing that, you have sort of a broader marketplace and you can feel confident in who you are supplying from. And this has a lot of important implications, particularly for reducing corruption type activities such as substandard and falsified medical products. That's for the supply chain. Then I think there's lots of learning that we can bring in due to sort of the failures of anti-corruption throughout the pandemic to do better in future. And we see now, and India is a perfect example of this, that there's now significantly more investments going to be made in the health sector more broadly. If I recall correctly, the commitments in India was to double the overall health spending. So in countries where there's now going to be increased amount of spending, but there hasn't been a sort of an increase in the emphasis on anti-corruption, well, we're going to have the same risks, but with significantly more funds. So we need to ensure that the funds are protected. This may require collective action around better public or more agile public financial management and sharing of independent audits and the like. And then the third thing I think, which is an important aspect of collective action, is engagement with civil society and engaging civil society within the greater collective action that is occurring in a country. There's so much opportunity to use the power of civil society to be able to do important activities such as monitoring the disbursement of medical products, to be able to demonstrate to the public that funds are being spent effectively and to be able to track and monitor that in a transparent way. And I think the most important aspect of that is certainly because through civil society, which are usually quite well established in a community, often have a lot of respect and trust from community members, you can bolster public trust in the institutions, which many of them have taken quite a hit throughout the pandemic. And certainly in many countries, people's trust in their institutions may be waning. So by bolstering support for community engagement, for collective action with civil society actors, we can perhaps save what has been lost as far as public trust in these institutions.
Thank you very much for that opening remark. And very interestingly, you said talk about learning and the progression, the manner in which we look at the learning, because you talked about supply chain, you talked about a blueprint for collective action, and more importantly, you talked about inclusion of civil societies in the entire program. And thank you very much for that, Sarah. I'm going to request Ashley, because Ashley, in view of the kind of Sarah laying down the learnings from COVID era, what has been the action points that UN Global Compact has been, and what are those learnings from the activities of Global Compact that we can bring it to the healthcare sector post-COVID? Just a brief outline from you and opening remarks. Thank you.
Yes, thank you. I must say, I thought I was just giving opening remarks, so I didn't prepare a list of lessons learned from our collective actions. But I can say that the Global Compact has been implementing anti-corruption collective action initiatives in collaboration with local networks like Global Compact India for the past decade. In 2019, we launched our current 4-year project, Scaling Up Anti-Corruption Collective Action within Global Compact local networks, to support collective actions from local networks and promote public-private cooperation in fighting corruption. So this project that we launched in December 2019 adopts a 3-pronged approach. So first of all, we're currently developing anti-corruption collective action playbook to streamline the understanding and uptake of collective action, when we plan to launch this hopefully in June. And then also, well, within this is the rollout of this playbook, which will have subsequent trainings in collaboration with Global Compact Network India. And lastly, we support Global Compact local networks in Brazil, India, Kenya, and Ukraine in developing and carrying out their initiatives, which is this initiative that Somnath brought up earlier, that the collective action under this project is the one focused on healthcare and pharmaceutical sector in India. In part of this project, the underarching approach is facilitating public-private cooperation on collective action through policy dialogue and engagement with governments and non-business stakeholders. And through this project, I've had the opportunity to work with the local network in India. And I should say, for the lessons learned throughout all the projects, I would say that stakeholder engagement and building trust within stakeholders is imperative. Awareness raising takes quite a bit of time. I've noticed through the collective actions that since we launched in December 2019, that it takes just quite a bit of time to get it even off the ground and determining what your overall objective is. And really also building upon and leveraging existing collective actions within the space, because you don't want to duplicate efforts. The whole point of collective action is really come together, not only just with your stakeholders, but other stakeholders, obviously, in the region and such as makes sense. But it's really identifying existing collective actions and leveraging the best practices, not only in your region, but maybe other regions. So I'll leave it at that. So thank you.
Okay. No, thank you very much, Ashley. I think we look forward to receiving that playbook, which would be a great learning for all across the sectors. Thank you very much for that. I'm going to move to the center of this topic, which is really the healthcare. And I'm going to request Dr. Malhotra. I think we've looked at patient at the center, I mean, at least during the COVID period in the healthcare sector. At one hand, or on one hand, we have tremendous faith, trust in the entire healthcare community, especially the healthcare supply chain. On the other hand, we've been hearing cases where, uh, come the epidemic, I think there have been cases of corruption which are galore. There have been cases where the hospitals have suddenly shot up their revenue models in a totally different, unconventional manner, and also looked at it as an opportunity to make money, which at one level is bordering being unethical, but it's also illegal and it's also a corruption at one level. Secondly, I think we have seen in the areas such as supply of PPE kits or some of the medical equipments, some of the consumables for that matter, I think have been not only found to be spurious, but have been found to have been procured through corrupt means. So on one hand, there is one extreme where we have tremendous trust and faith in the healthcare system and the entire infrastructure and supply chain. On the other hand, when you start hearing these cases during COVID period, we've heard them quite a lot, and probably the opportunist way to make money. How do we look at post-COVID era in trying to grapple with this situation, keeping patient at the center? Dr. Malhotra, your views, please.
So thank you very much for inviting me here to this very exciting debate and conversations. Well, I'm not going to defend the medical faculty this thing because yes, there were problems and there are problems and there will be problems. And a lot of problems have been because in India, there is a big divide between the private and the public. And the private sector has been put into an industrial. So the private sector gets electricity, water, connections, everything at a commercial industry level. So the medical facility or the hospital is an industry in India. Who made this? The government made it, the industry. Who made the charges? They made the charge. We have to, if you want to open a 5-bedded small nursing home, you have to take permissions at 32 windows. And imagine the corruption at 32 windows. What will it land up to the poor doctor who has just passed out and he's 35 and he wants to start his practice and start earning? His colleagues in the IT sector and all are earning and owning everything. So that's one aspect, but that's not my defense. Yes, what happened in COVID was COVID challenged the medical sector the maximum. And it challenged the governments also the maximum all over the world. And it was probably a bigger challenge, this pandemic, than the previous pandemics of influenza and plague. Because that time the medical services are a Medicare, and no one expected the medical services to stand up and win over the pandemic. But here we expected the medical services to win over this virus very quickly. Being the most advanced countries like USA started showing death rates which were unacceptable to a disease. And this virus actually took over the human chain and scared us to stay and locked up in homes. And now it has come back with a mutated forms. So SARS to COVID disease showed the world how precisely we are totally unequipped to fight deadly unknown viruses and pandemics. And the healthcare sector ran into all sorts of shortage. There was a shortage of masks, there was a shortage of personal protective equipment, there was a shortage of oxygen. The healthcare workers just disappeared from the hospitals. So there was a shortage of hospitals. The doctors poor stood up, but most of the small hospitals in the tier 2 cities were shut down by the government. That you cannot handle the pandemic, so only the bigger hospitals will work. Now, all this led to, of course, a big opportunity for the bad or for the ugly people in the system to earn money. A 35 rupee mask, N95 mask went up to 500 bucks. A 400 rupee PPE set went up to thousands of rupees. Substandard starting, life-saving drugs, escalated to 300 times, 400 times, started getting smuggled because everything was locked down. And everyone started thinking that this is, let's make hay when the sun shines. And the more severe the cases, more happy the COVID hospitals were, because they could charge whatever they want, because the government didn't know how to fix up the money. And I know the shortage was genuine, and escalation of price to little expense was expected and should have been accepted, but it went up to almost 300 times. Look at the racket of the PCR test. Now, if we say in India, PCR machine, which can do the test, every biological lab in every college has a PCR machine. But the government did not use those. They bought new ones. And they authorized only a certain labs to do it. And when the certain labs started showing an excessive or positive PCR test, they just banned those labs. Imagine in Agra, we were not allowed to do private PCR, RT-PCR test to any of our suspected patients. So they all had to go to the government. And then the government van would come once a day, collect the samples. You have to wet some palms of the guy who's collecting to collect from your hospital first. And then I'm told the kit, which the PCR is not very costly, but they were bought only through 2 companies. So probably a lot of money exchanged there also. Probably a lot of money exchanged in getting those PCRs machine in India and working only in a couple of labs. Why? This was all my money, taxpayers' money. The government did the test free, but on the cost of you and me who pay the tax. And then came the rapid antigen test. This rapid antigen test just flooded from China, the rejected ones. And for 400 bucks, 500 bucks, it was all available in the black market, gray market. The government supplied the rapid antigen free to the hospitals. But the guy would say that you take 100 more, I'll give you, those were 10 tests a day. But I could buy 100 tests from the guy who came to me to supply for 100 rupees a test. What is this? I mean, this was absolutely unacceptable thing which everyone did, and there were no checks on it. So it was in the form, they were saying like, we are also working hard, we are risking our lives. So what if we make a little bit of money? But that was not the right way it happened. 30% of beds in all hospitals were COVID hospitals, COVID beds. And they had, the prices were 300 times. So again, this should not have happened. This should not have happened. The multiple drugs used in India, even without evidence, the US and UK said only these drugs have proven, but we used everything on each patient. Probably that saved our patients, and our death rate, case fatality rate was much lesser than USA and UK. Still is, because they are not using the remdesivirs and the plasma because there's not evidence to back. And we in India do not rather believe in evidence. We believe in fighting the disease with whatever you have. You throw an atom bomb, you throw a fire bullets, you fire whatever you have, all the probably what worked in India, we don't know. The case fatality rate was definitely yes. And even the second and the third wave coming in, the seriousness is very much less. Then came the vaccine. Now the vaccine, probably there'll be no corruption in India on the vaccine because it's hardly any cost. It's 250 rupees, which the private hospitals, we are allowed to give it at, out of which 150 go to the government and only 100 rupees to that hospital for giving this vaccine. But the problem is that one vial is 20 cases and you made everyone started giving vaccine. If I don't get 20 patients in 4 hours, that vial goes waste. So if I open up a vial, I have to finish 20 cases in 4 hours. So it's a hell of a lot of vaccine which is going waste. And why are you wasting it? Give it to anyone who comes. So I think that issues are many. Some of the things which I feel could be done is we need very strict, stringent price control, which is reasonable to all of us. So there is no loss to the hospital. We need a reporting and a data management, very strict data management, because unreported cases have gone in India, unreported deaths have gone in India. We are not at the figure what we are showing. So probably there is much more behind it. We need many more window system to go away and single window for all registrations of the small healthcare facilities. We need to computerize everything in a central, so we have a central data. We need to increase the pay scales of the healthcare worker. We need to bring the doctors, the government doctors in India, under Indian medical services, just like IAS and IPS. Because an IAS officer fires the CMO left and right. Why? The medical officer probably is equal or maybe more than the DM of that city, and he should be handling pandemics, not the IAS officers. IAS officers should be handling the administrative part. We should be handling the pandemic medical part. And you don't do a FIR on a hospital because 5 cases were reported from that hospital, and you don't call that hospital a super spreader. This is a disease. It will come to everyone. So that was a big thing which we need to make India Atmanirbhar, self-sufficient. Make in India has to take a big role in especially PPE kits, N95. See, when there was N95 shortage and PPE shortage, I roped in all the garment manufacturers of Agra. Agra is a big garment hub, and asked them to make PPEs, gave them the standard, and they are exporting now. So their textile business stopped, and now we are exporting PPEs to all over the world. We need a lot of awareness, a lot of education. We need a good public-private partnership and good public-private trust. And of course, we need to change the system. We need to remove the junk, rot, and the rust from the system. God bless us, how we are going to remove this. The current PM is trying, but it will take a long, long time to do this. Thank you very much. These are some of my views on what is happening in COVID and post-COVID era.
Thank you very much, Doctor. A very insightful kind of narration and articulation there. Thanks for that. See, you stressed on public-private partnership, and I think you also talked about data management, but I'll come back to Christian a little later. But I would like to look at, and request Neville to kind of consider, this issue about public-private partnership. And is there a learning from corporate sector that's available today for healthcare sector? And what is that? Of course, your opening comments on the theme, Neville.
Yeah, fine. So first thing, thanks everyone for inviting me over. One thing which came out of this pandemic was people had large hearts. Rather, even if we did not have deep pockets. So once you have large hearts, people open up. They are ready to come forward. And that's what happened through individuals as well as through corporates who may not have been directly involved in the healthcare sector. Siemens, for instance, one of our sister companies is involved in the healthcare sector. The rest are not. But as a group, we decided to come and invest and contribute our might to fight the pandemic. One important thing is the public-private partnership. It has to exist, but we need to have a care that it should not cross the blurred line of a quid pro quo. Because the minute we have a quid pro quo coming in, then whatever the efforts are put in by a corporate is tinged with that jaundiced eye that it is being done to obtain a sort of benefit to the organization. And this is where my organization had to be very careful when we decided and we extended our arms to say, okay, here we are, we would like to do a contribution. Where should we contribute? So the most important aspect for a corporate is to identify the NGO or the agency which is leading the fight against the pandemic. Select the right one. Because once your selection is right, half the battle is won. Because then there is a comfort which comes into the corporate that they are moving in the right direction. And then the funds start floating in. Then the fund management starts floating in. And then you can give a comfort to the management. And I can share the Siemens way of meandering through this pandemic at a later stage to us. But one thing for sure, I endorse Doctor's view. Yes, there was corruption, but it's not such a bad world also. We were also floundering as a world. India also floundered. But in the end, I would say India is much better poised than quite a few advanced countries in the world as far as the fight is concerned. Maybe it's in our DNA, maybe it's in our genes that we have been able to fight it out better. We are more prone and more susceptible to microbes. They could not defeat us, maybe. Yeah.
No, very well said. Yeah. Neville, I think, yes, I will come back to you on the Siemens way of, and there are a lot of learnings for all of us from them. And I think I completely kind of endorse your view that, large hearts won over deep pockets. Excellent analogy there. Thank you very much for that.
Thank you.
You see, now looking at one of the critical areas that we have seen is while the kind of digitization got accelerated and accelerated to no levels, we were all working from home, the movements were controlled, and I think the digital space exploded. You see, I remember at the beginning or prior to pandemic, there was this issue about whether an online pharmacy can work and how can it work across various regions and across various countries, and whether digitally it is possible for somebody to look at setting up the pharmacy business. But I think pandemic has taught us better. We've moved and we've kind of we moved towards very fast, and I think we have accepted the digitization. Dr. Malhotra, you talked about the data, and I think the data management, the sanctity of data was one of the questions that everybody had in their mind, whether it came from WHO, whether it came from any of the government agencies, whether it came from civil societies and not-for-profit organizations. I think the sanctity of data always had a question mark. With this backdrop, I'm going to request Christian for his opening remarks with the focus on, the accelerated digitization, and therefore what are the challenges and how do we look at what to do post-COVID. Christian?
Yes, fantastic. Thank you very much. And thank you very much to my co-panelists for their remarks already. And I think we have plenty to discuss. And Narendra, thank you very much for your service, right, in the first line. So I think this is, one cannot imagine, right, if you are sitting in an office like this, or this is now the classroom where I'm going to teach later on, it's a different life. So I think when the pandemic started, there was this saying, we are all on the same boat, right? But it became clearly in a short period of time that we are in the same storm, but we are not on the same boat, right? So some are on super tankers and are not getting affected at all, and some are in very small nutshells and drowning. So therefore, I think this is also something that we need to consider. And I think what the pandemic also highlighted, like a burning glass, right? Where some issues are in societies that are already there, or that now became much clearer, I think. And I think one of those aspects was also related to digitalization and what we thought that digitalization will be able to do. And there are some buzzwords like machine learning, artificial intelligence, big data, and all these kind of things that we thought they will help us. And then we also thought that apps will help us. But specifically, at least from a European perspective, I think we realized that these hopes were too big, right? So, there, I think one important aspect is trust as well, right? So people do not trust that this technology will help, and then that the benefit of giving up, for example, privacy will overweight the loss of privacy, right? Or possibility of not getting affected or fighting the pandemic, right? So we see that there are a lot of things to address before we can really use, hopefully, new technology as well in order to fight corruption in a better way as well, right? So not only the pandemic, but also there are big hopes for the fight against corruption and technology digitalization, right? So we have the normal, what is called the cycle of for example, ethics and compliance management, specifically when we talk about private sector organizations, right? But I think also the healthcare and the public sector can benefit there greatly, which is related traditionally from prevention, detection, response, right? So these are the three ones. And now regarding the digitalization, some argue that we have a fourth part of this cycle, which is prediction. And I know, for example, World Bank is working on certain measures to find out what are projects that they are funding that are more likely to be affected by corruption, and in this predictive work then also try to prevent corruption before it's happening in the first place. So I think there is a lot of hope, and I think digital technology can be of high importance in fighting the pandemic and also in fighting corruption. But we need to consider the human factor there and issues like trust, as I mentioned already, and also the ability of humans to always work around these things. So if we think we introduce a method that will help us, for example, to fight corruption, then there will always be one person that finds out how to play the system anyway, right? So therefore, it's, I think then therefore, the education and training was already mentioned, awareness raising is still very much needed. So that people, have an ethical attitude towards their work and towards other aspects of life, I think is needed with or without technology, right? So technology can support and should support, but we cannot expect that it will help us to solve the issues. So I think as some opening remarks, I would like to hand over to you.
Thank you very much, Christian, for that. And I think you touched upon a very interesting aspect about trust, and we will come back to that element because I think that's the most critical element. But before doing that, you see, what's going on currently in my mind is what Dr. Malhotra just mentioned in brief, what Neville mentioned in brief, which is, there were all these wrong practices which were being practiced, so to speak, across various sectors, supply chain in healthcare, whether it is supply of consumables, whether it is equipments, whether it is healthcare infrastructure such as hospitals trying to do a completely unfair, unethical way in which they charge people. They tried to make money. But I think both of you kind of casually remarked, but we saved the lives. You see, that kind of brings me to the question, when it comes to life saving, is there a trade-off? Is there a trade-off that applies to say that, fine, so long as you are saving lives, I think corruption is okay, bribery is fine. And I'm going to start off with Sarah, because I think this is a fundamental and core as a part of awareness that I think, what is this a trade-off, and does this trade-off by any chance gets justified?
Well,
Sarah,
I think Yes, thank you, Suhas. That's a very interesting question. And I actually turned to Dr. Malhotra's head shaking. He said, no, like as you were saying, he shakes his head. And I think that when it depends really on the location. So there will be situations where hospitals and healthcare facilities are so underfunded that in order for them to be able to afford the supplies, in order to be able to provide the services, that they need to ask for informal payments or bribes. And that's not to justify, but if you have no healthcare service versus healthcare service with a bribe, then I mean, it's not to say that this is correct behavior, but one has to ask themselves, well, which is the worse or evil, really? So I think when it comes to anti-corruption, and I'll try to kind of bring this back a bit into a larger picture, I think within the health sector and with it, but together with the colleagues that I work with at the likes of the WHO and the Global Fund, we're having these conversations about how do we reconcile the ethical standpoint of zero tolerance with the reality on the ground. And we haven't come up with a solid answer to that, really. But the best that we've come up to so far is what is going to most, when it comes to anti-corruption, what is going to most undermine your objectives? If we have the saving of human lives or protecting the human right to health as our overall objective, then our purpose when it comes to implementing anti-corruption, either through collective action or otherwise, how can we ensure that those objectives to protect health, to ensure the saving of lives, how can we ensure through anti-corruption that that is maintained? What that then looks like is to not fall back on, say, what one might call the traditional types of anti-corruption that often increase the amount of burden or bureaucracy within a system, but how can we trim back bureaucracy to make things as streamlined and as agile as possible, whilst at the same time achieving those anti-corruption aims, but maintaining that health objective? It's a very difficult thing to do. But I would suggest if people are interested to look at the example that has happened in the Ukraine. So prior to the revolution that took place in Ukraine in 2014, they had a certain type of health system with certain types of anti-corruption or a lack thereof mechanisms in country. They undertook a serious reform and a number of different types of reforms that prioritized health and prioritized a more efficient health system, that it had more sustainability and was more fit for purpose. It wasn't coming from a place of, oh, let's stamp out all of the corruption, let's get rid of all of the corruption. It was more, how do we improve health outcomes? And what can we do that will sort of kill two birds with one stone, as you say? So we have one objective and we get two things done at the same time. And they implemented lots of different reforms. If you're interested, I can provide a case study on this. And it has led to lower rates of bribery. It has led to better access to healthcare supply and healthcare more broadly. It has increased public trust and public satisfaction with the system. So there are ways in which to do it, but I think to say, well, we need to stamp out all the corruption regardless of the health outcomes, if it improves or if it makes poor health outcomes, versus the idea of, well, we'll let some corruption happen because at least we're saving lives. I think there needs to be certainly a balance.
No, thank you, Sarah. I think it's a very interesting take. Sure, we would love to reach out the Ukraine case study across to our audience. And we're happy to circulate that. I will request Dr. Somnath Singh to do this subsequently. But there have been a lot of learnings in the corporate sector around this, when profit was the sole motive, like we today have saving lives as the sole motive. And I think the corporate sector has moved to understand that there is no trade-off between profits and corruption. although loss of life or lives is on a different footing, only the money and profits. But I think the company's survivals and large corporates have kind of bundled down on the issues such as bribery and corruption. But I'm going to request Neville, because Neville, I think, there have been these churnouts that have happened when somebody talked about trade-off between profit and corruption. And the very existence of the businesses were questioned, the sustainabilities were questioned. So what are the learnings from corporate sector on this, and how do you look at this trade-off situation?
So at one point of time, Suhas, there was always a trade-off. Should I maximize my money, or should I play the do-gooder? Once the CSR norms came into India, I would say that companies were forced to think about CSR activities. Okay, not just look at maximization of profits, but I would say they were coerced. I would use the words, they were coerced into using their funds for the betterment of the society at large. Slowly, good corporates, which already were doing sizable CSR related activities, though not under the umbrella of CSR, but they were doing it as a social service, like the Tata's group, for instance. They have been there doing it for ages. Many corporates learned the value of contributing to the CSR, not only from their company's standpoint, but also to give back to the society. So there was a slight mind shift, and the CSR rules did help in that direction. What's more important for an organization is the word sustainability. Only profit maximization is not going to make a sustainable business proposition. You have to have other standouts too to make your business model sustainable. And one is to integrate your company back into the society. And that integration takes place through one of the means of CSR activities. Now, when it comes to pay back to the society, corporates can just give away money as per their norms and then walk away. Some can do much more. Some just don't walk away, but partner the society at large. And this is where good governance and good corporates start partnering the society at large. Does it answer?
Sure. Yeah, no, definitely. No, thanks for that outlook. I mean, again, before coming to Christian, I'm going to request Dr. Malhotra. Dr. Malhotra, you were very vehemently nodding your head, and nodding head is typical Indian, So I think, yes, it's a very good sign either way, when you're saying no or you're saying yes. But Dr. Malhotra, your views on the trade-off.
So what price would you put on a human life? So that is what you have to decide when you talk of trade-off. There are all of us who have worked during our training periods in the government. There are all of us who, even in the biggest of corporate hospitals where nobody can get in without paying inside first, have done lots and lots of free services when it comes to a patient dying, and when you can save this patient by. Then you don't start thinking of he has to pay me first before I try to save him. So that doctor in you, in all the doctors, is always alive. It is the businessification of the medical profession which is at fault. So which I told you in the beginning. So once you take us out from the industrial laws and the taxes and this thing, you see how the medical services will come down, and how many more lives will be saved because it will make the whole healthcare system very, very affordable. So that affordability has to come, and everyone, there's a great initiative by our Prime Minister on Ayushman Bharat. Go into private, any hospital, get the best of treatment, and the government will pay for it. Yes, but that doesn't take care of. He says 50 crores people will be affected. So that's almost all below poverty line would come into it in India. But still, it has to be implied, and it has to correctly, nicely, and ethically, and with the right kind of backing and the right kind of public-private partnership. So I say there is no price on saving lives. any n amount of money you give me will, if I've saved a life, is not enough for me, or I don't look at that money, I look at that life which I've saved. So it's a total different mindset with most of us on when it comes to real saving lives.
No, thank you, Dr. Malhotra, for that. Christian, your views on the trade-off and any learnings from here?
Yes. Well, thank you very much. And yeah, regarding the trade-off, I did a study a couple of years ago that was published then in Journal of Business Ethics as well, where I asked the question of what are causes that people would accept as justifications for corruption. And one of those that had high rating on acceptance is saving health and life, right? So that, and I know that a lot of companies, multinational companies, for example, in their codes of conduct, they have this exception if you are, I don't know, at the border and there is a police officer or whatever pointing with a gun to your head saying you have to pay this, then they allow their employees also already in the code of conduct that in these critical exceptions, they are able or they can pay, but then need to immediately report that this incident happened. So I think this is really clearly a huge ethical dilemma when we talk about corruption and saving lives. But I think I would like slightly to disagree with Sarah, if I understood her point correctly, that in this case, we could accept it. And let me just give a slight example, a real life example, unfortunately, happening in Mexico this year with a dear friend of our family. The father of the dear friend unfortunately died of COVID, and he was hospitalized for more than 14 days. And for example, they had to bring the own oxygen because there was no oxygen in the hospital available so normally, so to speak, right? So it disappeared, and then people started to sell this on the side, right? So you can now say, okay, this is a family, I would say like middle-class family, not very wealthy, not very poor, right? So they had the financial means to sustain this for a couple of days. It was not successful at the end, unfortunately, so he passed away. But I think when we open up this box, right, then we have always the poor's worse off, right? So then it's really the rich fight for themselves and the poor are left behind, right? So if this, and we already talked about this divide in societies, right? And that in emerging countries are even bigger than in European countries. But also here, we saw that vaccine was also already mentioned. We had in the first couple of days an owner of a private hospital in Switzerland getting vaccinated. But there is a clear system who gets vaccine first, right? So, but he, as he said, I'm the owner of this hospital. Then he said, yeah, it was a test or something like this. But now it's clearly that there we have, we need to stick to the rules as well, right? Because if we don't, the most vulnerable will suffer most. I know that this is a little bit, let's say, out of the textbook, and real life is a little bit different, but I think if we already in approaching it, say, okay, there might be issues where we can open the Pandora's box, then we will have it widespread.
No, thank you very much, Christian. And I think you tried to make this point about ethical dilemma, and I think I'm going to come back to Sarah on that, because you see, while on one hand, what you're trying to say is that if somebody points a gun at your head, You will be coerced into entertaining corruption, and that is excusable. That leads one to believe that while there is an element of coercion in the corruption, but if the demand side of the corruption makes itself so ethically strong that there is no coercion at the point of, let's say, transaction, if I were to put it loosely, or which triggers the corruption. You see, therefore, bifurcating the demand side and the supply side and making sure that at least on the demand side, you have all the principles very correctly articulated, made, and implemented. I don't think if the cop is going to put that gun onto someone's head, if he is taught to be not corrupt, and he embraces it to be not corrupt. And again, we'll come back to the trust factor, because that's going to be one of the primary concerns all across. But Sarah, on this one, of course, the ethical dilemma that Christian talked about, saying that yes, it may be justifiable at times to compromise on the principles of corruption, anti-corruption and anti-bribery, I'm sorry. But in that sense, what your views would be for the ethical dilemma, and bifurcating bit on the demand side and the supply side?
Thank you for that question, Suhas. And I think it's at this point, it would be very important just to say I'm not advocating a corruption in any case. That's certainly not what I would hope would not be the takeaway from today. I think that to speak to Christian's example that he raised, when I say that if a health center does not have the needed supplies, if in order to get those supplies, that there is sort of a systematic taking of bribes, because the health center and the providers, the healthcare providers themselves, are so poorly resourced, then I'm not saying it justifies the taking of the bribes. I say there is, here we have that ethical dilemma. Do we say, okay, we're comfortable providing no service versus providing a service that, yes, has a bribe attached to it? I'm not saying that either is particularly correct. I'm just saying I have a level of empathy for the provider at that level. And that's not to say at all that this systemic issues should be addressed and that there should be efforts made, because if we look back to what is the source of the cause of the corruption that would take place at the very, very low service provision level. If we have healthcare providers that are poorly paid, if we have healthcare centers that are poorly resourced, and that is leading to bribery and patients having to pay extra for public services, then it becomes very clear, what do we need to address? We need to address the poor wages, and we need to address the overall systemic resource limitations. That often gets us back to more the central government levels, and that takes us beyond the health sector. And I think that's where a lot of work needs to be done to increase transparency around public funding, to increase transparency around donor spending in countries that rely on overseas development aid, to increase transparency in procurement and similar aspects, so that we can better follow where funds are, what funds should be available, and where these funds are being allocated, / where are these funds then going missing. And I think that brings into what I was speaking about before with regards to the involvement of civil society, because there we have a resource that we could use to bolster attention to these types of issues. If we include the media in that, to raise the alarm of these problems, and to start to generate a stronger civic voice. In fact, research that's been conducted by a colleague of mine, Dr. Alina Munju PPD here in Berlin, it has found that 70% of the variation in corruption occurring in a country, and this was done in Eastern Europe, but I would presume that some of the findings are transferable to other contexts. But in this case, 70% of the variation in corruption is actually due to the level of civic engagement. So there's a lot to be won from having more civic involvement in these types of issues. And yes, just to state once again, I'm not advocating for corruption, but as it was demonstrated, and I think Christian actually highlighted it very brilliantly, it is very much a contextual and sort of a situational issue. Certain situations may, be very ethically problematic, and other situations you would say, well, of course we have to allow for a bribe being paid when a gun is held to someone's head, and that ethical dilemma, I think, is very contextual. So I think I'll stop there.
No, thank you very much, Sarah, for that. Dr. Malhotra, I'm going to come back to you, because I think this is the part of the ethical dilemma that forces me to look at demand side differently from the supply side of corruption. What I mean by that is, if, for example, all healthcare facilities, the entire supply chain and the infrastructure was completely ethical and was not conducive to coerce somebody into bribing, there would be no question. While somebody saying that, please save my life, I don't mind paying you whatever amount of money, whether it is corruption, whether it is bribery, whether it is breaking of any of the laws, whether it is issue on the ethical dilemma, that I can understand from the supply side. But from the demand side, who is demanding the money at that point in time, trying to save a life, one, of course, it is not justifiable. But when you try to bifurcate this, then we look at what is the agenda. How do you bring out that awareness at the demand side? How do you make sure that you have not too many instances of the nature that we currently have?
So it's a very interesting situation. So let me take you back to 1984, when we were residents. Both me and my wife were together residents in the same hospital. It was a government hospital, very big and a very busy time. And our boss said that no one is going to die of lack of care, or a lack of a suture material, or a lack of a Hemaxil bottle, life-saving for blood pressure falling. And because we were working in obstetrics, so every day a villager patient from PPH in very morbid conditions with fits, with jaundice, we used to face everyone. So if as the junior most house surgeon, if I did not have those drugs in my cupboard, I was penalized. Where I would get them from is my headache. The government supply was not there. But as being the junior and the junior most in the chain, the boss is operating and she says, I want these things. The patient is very poor. They've just dumped the patient with us and ran away. And we have no one to look after them. This is a true life story. And it's just me and that patient. And it's a dying woman who gives birth to a child, and we have to save the child and we have to save the mother. So what we used to do is, we used to get some affordable patients also for surgeries and all. So from the affording patients, we used to give them a list of double the equipment to be used. And we would save one of the set for this poor one, which will come at midnight, where we would have no equipment. So I don't know whether I was corrupt at that time, but my ethical dilemma, being a fresh doctor, was that I have to save every life. That was in my head. I've become a doctor just for that. So whether I was corrupt, charging extra to the patient who could afford and who had no qualms for it, and using half of what that operation saved to save a real life. Then when we came to the Agra Medical College, so again, the similar situation. It's a government, it's a state-run medical college. In the 1980s, there was nothing there. There was nothing. So this patient comes, the electricity was a major problem. So we had generators, but we had no fuel for the generators. The fuel for the generators had to have been indented 3 days back, and someone would bring it, someone would steal it, we don't know what. So midnight, there is no electricity, and this patient comes who needs an operation immediately. But we have no diesel. So if with the medicine which he has to bring, if I write, please bring 2 liters of diesel also, who's corrupt here? whether I've saved that life just because of 2 liters of diesel, so I have 2 hours to do the operation of this patient. So that's where do we put a price to life, and who pays for saving that life? I'm still in a dilemma. It's been 40 years of practicing now, seeing death so close, seeing saving patients so close, seeing mothers die in villages without any help. So I'm still in a dilemma. I don't know what the correct answer to this is. And as Sarah said, I would charge double to the guy who can afford to save another one who will not be afford. And I would not call this as that I'm correct.
No, thank you very much, Dr. Malhotra, for that candid kind of a articulation of the situations that we always face. And I'm sure all of us face these situations all the time. But I'm going to request Neville for his views on this trade-off. And you know, I mean, completely there used to be profit objective, and therefore you ended up kind of making money. Every corporate wanted to kind of fix things, and they were not sustainable. How do you correct the supply side, and how do you kind of look at then improving the demand side?
First of all, it all depends upon the corporate's philosophy. Like Siemens has a philosophy: zero tolerance to corruption. So if I have zero tolerance to corruption, then there is no semblance of trying to agree to a bit of corruption in my company's life. So even if it furthers the cause, let me be corrupt. No, there is no way out of it. Zero tolerance means zero tolerance. No corruption means no corruption. The two are divorced. Having said that, it depends upon the philosophy of every other company. So there's no hard and fast rule which I can apply to all companies. This is what I apply is to my company where I work. In order to safeguard an organization, the way we call it backward integration and forward integration, you need to also make sure that your supply chain is as clean as your own organization, and that you work with vendors who are either as clean as you, or you force them to turn clean. Now, it depends upon what is your intrinsic muscle power of your company and how many vendors are willing to work. And I have seen at close quarters in India, though we call ourselves a high-risk country with a lot of corruption, there are quite a few vendors who have come in contact with Siemens who were never corrupt in the first instance. It's not that we managed to change them. No, they were not. They did not like the society. They did not like the circumstances under which they were forced to operate. So given an opportunity to work with an organization which wanted clean business, they also wanted clean business. So it was very easy for them to adapt and adopt. So it's a myth that in India, we have only corrupt business flourishing. No, we have good business also flourishing. They're few in numbers than the others. They're hidden from the sight. We need to just be less myopic, I would say, and open them, bring them to the forefront. Because once people see them flourishing and thriving in a corrupt environment, but in a non-corrupt manner, people will start to adopt. They will start to follow the footsteps. Having said that, just a minute. Having said that, in order to ensure a supply chain which is corrupt, it also depends on the selection procedure. Your own company's procurement team should be very good enough, very smart enough to know what is in the market and scout for it. And once you do the necessary scouting, by word of mouth publicity, people will start approaching your organization to do business with you.
No, that's kind of a very interesting analogy that you actually set the benchmark on the behavior itself, so that everybody kind of follows you up. But thank you very much, Neville, for that. I'm going to request Christian for his views on the kind of ethical dilemma at one end, the difference between the supply side and the demand side. What is it that goes on there? When we look at the trade-off with life and look at supply side, demand side there. Because my firm belief is, if the demand side is absent, there would be no supply. And
yes,
that,
so this
in
is
my view, is the answer to the trade-off. But I want to hear your views, Christian.
yes, thank you very much. I think this is always like the chicken and the egg. And what I realize when talking to people from the private sector, then they tell me, I would never pay, but I'm asked. And if I'm not paying, then I'm out of the business. And when I talk to people from the public sector, right, they say, I don't expect this, but they offer me, right? And what should I do then, right? So this is a little bit this chicken and egg game that I'm not sure whether this is at the end helpful, right? So I think, and OECD, for example, introduced heavy instruments on the that is taking more stock of the supply side, right? And I think it would be recommendable to have similar measures also for the demand side, so to speak, right? So I think this would be necessary because a lot of people from corporations, they tell me that we did a lot, but at the demand side or our partner side, so to speak, they're still the same persons and they act still like before, right? So back in the 90s, when also it was and Siemens is an example of that, right? So that it was normal to do business like this, early 2000s. But I think the supply side changed there strongly. Hopefully, at least this is what I get when I talk to people there, right? So, but the other aspect that I would maybe like to mention, getting back to a discussion also earlier, I think it would be necessary a little bit to reflect on informality in not very formalized environments. Like we, from a European perspective, we are in very formalized and highly institutionalized environments. So that there is no diesel, for example, in the hospital, or that the police has no diesel to reach out to communities or something like this, right? In cars, which are also example that I know firsthand. So this is from our perspective, it's not imaginable, right? So the police has fuel to go there. There is fuel to run. There is electricity when it's needed, things like that, right? So therefore, I think maybe sometimes we are not talking about corruption as perceived maybe in this more legal sense, but in informal institutions that are happening. And for example, a couple of decades ago, also in Europe, it was normal because the teacher received only a small salary, but it was clear that every month, every child has to bring one chicken, because otherwise the teacher would die, right? But this was clear, right? So everyone knew that the price, that is not official, but it's there. So everyone knew this is the price, right? And also when this happened everywhere, in every village, right? So then I think there we are not talking about corruption, but sustaining a system so that is not completely publicly funded as it should be, right? But then it's clear that this, it's not for this is one chicken, for this pupil it's 5 chickens or something like that. So the price is clear as well, right? So there are price, and there could be price differentiation as well. If you say this person is richer, he can afford more, right? So, but then even then it's clear, right? So there are different levels of services that you provide, and it's not official as we would say from a Swiss perspective, right? That it's written in a law or something like that, but it's known to the community and it's common practice. So therefore, I would then refer more to informal way of doing things and not to corruption per se, right? So maybe this might be a helpful way to distinguish between different institutionalized environments.
Yeah, thank you, Christian, for that.
So, Neville, just want to add to what you have said. Even
Sure.
the government has realized that cutting off the supply side is much better than trying to shut off the demand side. And that's the reason why, if we look at our own law, the Prevention of Corruption Amendment Act, it is now focusing on the supply rather than the demand. So you bring a full stop to the supply, automatically the demand will dry off. And this is where the focus, is going to be in future.
No, I think that's where probably the dilemma comes when you're trying to save lives. You want to save your life at any cost. But Neville, we will talk about the prevention of corruption at completely separately, because that the rules have not been framed. The amendment is 2018, and I think it's getting dragged on and on. But having said that, I'm going to now, I'm probably running out of time. Therefore, through this discussion, and I never wanted this to stop because I think it's going to the interesting levels. A couple of issues that kind of got brought up is, how do you kind of strictly implement the rules, regulations, and make sure that the compliances are done? That's one area. The second area is that an inbuilt trust, which Christian talked about initially, and that was the underlying thing all across, to say that trust is the essential kind of an element of ethical behavior, and that needs to be re-established. If that has kind of taken a beating during COVID period, I think it needs to be reinstated back. We need to revisit the ethical issues around the trust. But I'm going to start off with Neville this time, and we'll do a bit of a circle back up to Sarah. Is what is that one thing you would say that post-COVID era in the healthcare sector you would want to see to ensure that the corruption and bribery related issues come down drastically? What is that one factor? Neville?
Accountability.
Great. I'm going to request Christian, one factor.
Well, I think it's personal integrity by all people involved.
Okay. Dr. Malhotra?
Recognize those who are not corrupt and award them.
Oh, okay. Award about very good. Sarah?
Yes, one thing I think that is really important, and you've spoken to it, is the issue of public trust. And I think that can be kind of garnered through what Neville described, accountability. There are sanctions, there are legal devices that can be applied to hold those who are on the demand side accountable, but they're not being effectively used, or when they are being used, the speed at which they're being used is not satisfying. It's not fast enough that people can see that there are in fact consequences to being corrupt. And so I think that with regards to post-COVID, there needs to be considerable amounts of investment put into retrospective auditing of procedures to be able to identify who actually has done wrongdoing, who has engaged in corruption, and then to hold those individuals to account.
No, thank you very much, Sarah. I must say I'm conscious of the time, and I have to, that's my KRA to finish this within time. So I have to kind of look at my performance around the KRA there. But thank you very much, Sarah. Thanks a lot, Dr. Malhotra. Thanks, Christian. Thanks, my dear friend Neville, for participating in this panel discussion. Thanks a lot, Ashley. I think we will learn more through this period, and I'm looking forward to that playbook that you talked about. I'm very, very interested in understanding that and how do we translate that into great learning subsequently. Thanks a lot to each one of you. I thought probably this shouldn't end and wanted to go on and on, but I'm conscious of the time, and thank you very much for participating here. Back to you, Dr. Somnath Singh.
Thank you very much.
Sir, may I request Dr. Sip Tripathi? I think Dr. Sip Tripathi, he has to give the key takeaways from the session today. Dr. Sip Tripathi.
Sure. I think, would you want to briefly introduce Dr. Tripathi to our audience and then request him to speak?
Okay, sir. He's Dr. Tripathi. I think he will explain himself, sir. So I'm waiting. Dr. Tripathi. Sir.
Yeah, can you hear
Hello.
me?
Yes. Yes, yes. Clear,
Yeah,
sir.
can you hear me?
Yes, sir, please go ahead.
Very good evening, good morning to everyone. Thank you for such a wonderful discussion, panel discussion. And my name is Shiv Tripathi. I work with IIHMR University as a professor. It's a healthcare management research university. This is about me, and I have been working in area of collective action and anti-corruption, particularly with reference to management education. Just very quickly, because I understand the time and most of the speakers have explained almost all the dimensions that has been covered in a wonderful way. Just I would like to touch on one or two things very quickly. One is what Dr. Narendra Malhotra mentioned about the care situation at the village clinic, where one patient could afford and another could not, and then another example mentioned by Christian, who talked about the Swiss school teachers and how it was not official, but they used to offer something. What I would like to just mention here, that when we we either treat it from the demand side or we treat it from supply side, rather looking at the entire ecosystem. And when we look at the ecosystem, this is something what I call is around the grid rather anything else. And the line is very gray, where demand influences the supply or supply influences the demand, as Christian also mentioned about the chicken and egg. Drawing from the examples what Dr. Narendra mentioned, we have to see that corruption is contextual and it's evolutionary in nature. And when we are trying to find the solution, it may not be universal for every context for every country context, every regional context in one way. Implementation may differ because contextual factor, resource factors, all these issues have to be considered. We can't see moving towards ideal is a good thing, but just keeping that, making it static may be a very, very challenging, and it may sometimes create many of the dilemmas. And that's why we keep on discussing the dilemmas and keep on improving it. So that's what I would like to reflect on. And I think that everyone has already spoken so much about, so I would not like to add. Thank you very much for giving me this opportunity.
Thank you, sir. And at last, on behalf of UN Global Compact Network India, I thank you very much all the speakers for your insightful discussion and the recommendation. And also, I would like to thank all the audiences for their patient, listening and the precious time. Thank you very much for the session. Once again, thank you.
Thank you, everybody. Log off. Have a great evening. Great day ahead.
Thank you very much.
Very good morning.
Thank you, sir.
Thank you,
Thank you,
panelists.
thank you,
Thank you,
everyone.
audience.
Thank you, audience.
Stay safe.
Thank you, sir. Thank you. Bye.